Добрий день всім. В нас дуже незвичний
Good
сьогодні
afternoon,
такий
everyone.
сеттинг,
So
де
we
ви
have a
бачите аж
pretty unusual setting. So hosting three visitors. So let me see if I can manage the three. So handle them really simultaneously. Three online speakers. It is a super opportunity for us because all of the Henry Marsh, who is a writer and British neurosurgeon, and hopefully a lot of you have read his books before. Andriy Myzak, who is neurosurgeon, and Oleksandr Babliak, who is in charge of cardiosurgic, so units and so less invasive surgery, so Dobrobut hospital. And also he is a freelance advisor to the NHSU. So let's carry on. Is medical education so topping our agenda? Those of you who will have simultaneous input and both in the online, so we have Oleg Lutenko. So greetings to you, Oleg. So we have simultaneous.
You come to Ukraine for many, many years already now, and you work with all different people, and you give speeches, and you talk to students, to young doctors, to the experienced doctors, and you know Ukraine very well. What's wrong with our medical education? What is the essence of the issue according to you?
It is too hierarchical. It is too rigid. It is too vertical for a single description. As you say, I've come to Ukraine for many years. 32 years is because I love the country and I have many friends here, and I think the country is very important. I've always understood that, and I do not come to criticize, I come to help, but medical education here is terrible compared to the West. I'm not saying the West is perfect, but there is no question of the fact that both for undergraduates, for medical students, and for young doctors training to be specialists, the system is very, very poor. And some of that, a lot of that, is because it is still the Soviet, communist, Russian legacy. It is also because Ukraine is not very wealthy, and it is because of its tradition of hierarchy, of senior professors and who run the system.
What's wrong with hierarchy? Why does it impact the education?
Well, it depends, but the problem with hierarchy is that people at the top of the system have a distorted view of what is good for everybody. They tend to think only about what is good for themselves, and they lose sight of what is important. Also, the problem with hierarchy is that we all make mistakes, and good medicine is not just about knowledge and knowing how to treat patients. It's about safety, because medicine is very, very dangerous. Even in America, every year tens of thousands of people are killed by mistakes made by doctors and nurses. And patient safety is very, very important. And if you have a very hierarchical system, it is actually very difficult to establish patient safety, because patient safety is all about being open about making mistakes, recognizing mistakes, and then working out how to not make that mistake in the future. And if you have a hierarchical system with godlike professors at the top, they will deny mistakes. They will say, I never make mistakes. And the system as a whole is not good at learning how to practice good, safe medicine.
When people ask me what's wrong, I always start that absence of English is very wrong. What do you think about that?
Well, I'm afraid that's true. English is the lingua franca of medicine, and you cannot really make progress in modern medicine if you don't speak English. Obviously, so much of the modern research and technology comes from America, but my own country, England, has a very strong tradition of critical, evidence-based medicine, and a very strong tradition of what we call bedside teaching, where the teaching both of the medical students and young doctors is actually on patients. It is the emphasis is on seeing patients, dealing with problems, not going to lectures and learning long lists of facts. Most medical schools now in England and America, I can't speak for Europe, use what is called problem-based learning. You do not give the students a big list of diseases and symptoms. You say, here is a patient, talk to the patient, go and find out what the problem is. And this encourages the students to talk to patients, to think for themselves, and to learn to become good data miners, and to learn to use what evidence is there, which is much easier now because of the internet.
Що ви, Андрій, думаєте про це?
What do you, Andriy, think about it? So I have appreciated the statement by esteemed Dr. Marsh that he is here not to criticize but to support. So we have a long-standing tradition, not only the medical tradition, so we have a paradigm embedded here, that any attempts of the kind to stretch out a helping hand, so to share advice and to point down to possible mistakes and errors, for them really to identify so as really to avoid these, sometimes is perceived as a destructive type of behavior that is detrimental to hierarchy, as an attack, as an onslaught, and not a criticism. And it goes without saying that those people who are really on the top of this hierarchy, so they have a lot of intimidations because there is no really, because they've been exposed to this crippled training education, so in Ukrainian circumstances, and they feel very defenseless. So any type of meaningful critique or criticism or meaningful advice is perceived as destructive. And we had a previous talk with Oleksandr, so we've inherited it, not really to say through in the course of decades, but hundreds of years, so in our tradition, so in any walk of life, and we have to start fighting against it. And it's all about really the maturity of not yet society, but any individual, is the capacity and skillfulness to acknowledge their mistakes and to draw conclusions, and let alone so with a follow-up extrapolation to allow to share the mistakes with everyone else, so as really to stop to put paid for it. So if it's called Mobility and Mortality Conference, in Ukrainian, it is really clinical insights into the case studies after some bad experience has happened. So in the military terminology, and so in the English speaking, it's all about really our survival after action review. And you must learn what it takes to do this introduction of this after-action review. But my personal experience as a clinical practitioner, so really says that the system is being too resilient, so it's really onto its defenses, so it's really to stop it from introduction. We've had a very fascinating conversation with Sergei Vereshchuk, a doctor from Odessa, very progressive-minded, so he's in charge of polyclinic setting, so where the primary healthcare service delivers. So, and his statement is all about, so everyone is talking about their very good success story. Let us get together and let us talk about the medical fuck-up nights. And I supported so brilliant idea. So how you, Oleksandr, do you treat your criticisms in relation to you, and what do you do in your own team? So it's really to nurture this culture. So it's really to have someone coming in saying this is not okay, let's do about this, let's sort it out and so on. First off, to be able to hear your criticisms, and so as really to be able to respond adequately, so you should be pretty resourceful and you should be pretty strong insofar as well protected, and also well protected in your own professional persona, and also well protected with the logistics and arrangements. So basically, I find it easy just because myself, so I feel myself, and also both as a specialist, as a professional likewise. So if any type of criticism, so in my relation coming into me, so helps me to sort it out. So I will just be thankful for it. But my pathway towards it, so wasn't that easy. So when I was a younger lad, so when I was a younger position, and when I had, so I was challenged with various situations. So, but indeed, so it is a challenge. So to be open-minded towards the criticisms, and this is a challenge for most Ukrainian clinicians or physicians, because very often those criticisms are being used just to have some after effect. So it's not really to delve deeper into the case study. So it's really to ensure the process in its making for that matter. So to cut above upgraded this process. And my quick comment here to say it's actually so based on the statements from my colleagues, and I once again would like to underline here that so we have gotten used to think that it was the COVID-19 and both the war and about all this remote medical science learning or education kind of has brought about so medical crisis. But indeed, I'd like to share the feedback of my colleagues that the crisis in the medical education so long since been here. So this is something that we've inherited, and the challenges have aggravated it and have made it fully evident for that matter. That is the point why we are here together. Here now, what can we do together and really to partake of this experience? So from first hand.
So in the situation when you have very reluctant system, which is very hierarchic and doesn't want really to change, what is this magic thing which might change the equation?
Well, there is no magic.
Okay.
It's complicated. It's difficult.
But at least, are there any chances to start with something, and what it is, according to your opinion?
Well, you have to start by accepting there is a problem, and it's a deep-seated problem. My own feeling is you try to set an example. This question of honesty about mistakes is a problem in all medical systems to a greater or lesser extent. And in my own country, in England, in my lectures internationally, Ukraine is not the only country I come to, although it's the one I come to most often. I try to talk and be honest and talk about the mistakes I have made, and I feel personally it's very important that senior doctors set an example. Now, you're not going to get that in Ukraine. You're going to have to wait for a generation of old men to...
Actually, I will interrupt you here because I don't believe in this change of generation, because if you continue multiplying and doing the same, the next generation will be totally the same, well, and I can see it already. So is there anything...
Well, you have to show there is a better way of doing things, and that, I think, involves speaking English and exposure to medical training in different countries, and there are big differences. I mean, I know the postgraduate training system in Ukraine there are attempts to change it at the moment, but in Britain and America and Europe, after your 5 years in medical school, you will have probably 2 years as an intern, and then 6 years of specialist training, where you are actually dealing with patients all the time.
How do you make sure, how can you guarantee, or how can you even make a statement, for example, our education in England is good? What are the basis for it? How do you know?
Only by what I see with my own eyes and what I hear, and because of my language problem here, I fully understand. I only see a small part of it. But the tradition of postgraduate medical training in America and Canada and England is basically based on patients. It is not based on going to lectures and on theoretical teaching. You are there as a doctor working in a teaching hospital, seeing patients every day, with relatively little theoretical lecturing. It is left up to you. You have to pass exams. The emphasis is on finding out for yourself, and you are dealing with patients. And also there is a tradition, a culture that all doctors teach. It is, you don't have to be paid to do that. It is part of your duty. You have a duty to your patients. You have a duty to teach the doctors of the future. And some doctors are more enthusiastic about that than others, but it is very much part of the medical culture and tradition. And I don't know whether that's the same here in Ukraine at the higher levels of the hierarchy. I mean, my impression is often the tradition is that of teaching the professor's son and not teaching anybody else.
What would happen in England, for example, if you are an intern, a resident or whatever, young doctor, and you suddenly see that this big professor is teaching you nonsense?
Well,
what is your way in this situation?
Well, let's say if you see your senior professor making a mistake. Well, this is something now, it's legally by law in England, we have what is called a duty of candour. We can be sent to prison if we hide a mistake or do not report a mistake. And the model for this is from the aviation industry, where everybody, the pilots, the co-pilots, the air stewardesses, the engineers, are all trained to report mistakes. Now, it's easier in aviation safety because if your plane crashes, you were killed. The problem in medicine is when doctors or nurses make mistakes, it's the patient who suffers and they don't. But there is it's difficult, but there is an increasing attempt to try to create what we call a no-blame culture, so people report mistakes. Having said that, again, you see in the past, the English system 50 years ago when I started was more like Ukraine. The senior doctors were godlike, and your career depended entirely on them. If you criticized them, that was the end of your career. But now in both in England and America, your career is not determined just by the senior doctor. It's a much more complicated system with many more people involved in deciding how you move up through the training ladder.
Why? How did it happen?
Good question. I think it took many years to develop. Partly, I think, because of research on outcomes and showing you get bad results if you do not have good, or for showing that good team working, and good team working is about argument and criticism, is not just about everybody agreeing. Good teamwork is very important for getting good outcomes. We know that it's like in the army. A bad team does not fight well. It's the same in medicine. So there's an increasing emphasis in training to try to tell young doctors that teamwork is just as important as their ambition and their egotism. But again, of course, the problem in Ukraine is doctors are paid very little by the state. So doctors are in economic competition. And that really isn't a problem in the West. We all are paid enough by the state. We don't have to fight each other for money. And that's a big problem.
Andriy, refleksujte.
Andriy, please share your reflections. So from my own behalf, I just would like really to wedge on in the conversation when Henry is saying that. So we managed really to change it because we investigated the outcomes, and perhaps I would like really to take a pretty dim view of things here in Ukraine, because I haven't seen the hospital that is very above and honest, checking out, observing their outcomes. I haven't come across this yet, so please go ahead. So it's a painstaking issue, and my message to you is as follows. So by the traditions, so that Henry has been referring to, so is not really borrowed from England. So they are the ones really stemming out from the culture and from that input and that education. So available and been embedded in that culture for decades on end. And if you would like to draw a comparison between some things that we have in the West available with our unavailability, and our physician only can operate and can be hired, so in the hospital, so pursuant to their labor agreement. And so there is small leeway for the physician really to have their own liberty at hand. So if they really have a clash, if they run into conflicts with a big boss, and the big boss, so in our own setting and in the West likewise, so whenever back in 1999, so I traveled to Australia, and this is where I came across so such big bosses that everyone was afraid of them virtually, and the residents in the cardio surgery really told me straight up, so don't really mess up with Peter Brady. So, and I just found it really so. And after 2 months, so I had a conversation with him that left me deeply shocked. So can this really happen? So can you really treat the resident in such a way? So it's really to tell them off, so in such high tones. So to my best understanding, so it was a trifle. It was a trifle thing, but indeed so. And I hospitalized the patient, so under his name, so not seeking agreement over the telephone. And in their own mindset, it is about a higher accountability to share. And it's, I think that's likewise for myself. You might want really to bring it to me more delicately. But unlike those big bosses available in their own setting and our own big bosses, so you can see a professional standing. And I just would like all our prominent bosses, big bosses, and they're called big dogs in America, they're called. So to make them accountable, so to make them fully accountable for their own status, and from the other hand, to ensure that our physicians could have access to the big choice to make. So really to, so if they break up with somebody, they should be able to be employed elsewhere. We don't have this choice. And my colleagues, going back to the education matters, Dr. Marsh has now said, so perhaps we might need to draw our attention still more so to the fact that in the culture of his land, so most senior age physicians do acknowledge that it is their mandate to train, to moral duty, to train their younger generation, whilst in Ukraine it is pretty prestigious, so to make a successful surgeon. So everyone is saying that he is that he is he's got hands of masterpiece, and my relative has been operated by Babliak, but in Ukraine. So for some reason, so it is not prestigious to be a teacher, and I think that it should be, may be changed. So we should be implementing the culture to make sure that you've got our, so whenever someone's got their own students, so it should be in demand as a profession, so as to enhance the standing of a senior physician, to make sure that he's got his own disciples, i.e., those students. So I'm reminiscent when I was last time in London, and I was sharing time together with one of the students of Dr. Marsh, and we were talking about neurosurgery and colon neurosurgery. And Timothy Johns, so who was the student of Dr. Marsh, really said, "Yeah, well, you know," and I think that we should really credit Dr. Marsh and the fact not that he kind of saved so thousands and thousands of people's lives, but his main merit is all about the fact that he has so trained hundreds and hundreds, so marvelous neurosurgeons world over. And actually last night Henry told me a story when we talked about the topic, so the upcoming topic for this after this morning, so about the training of the younger surgeons, how to correct their mistakes and how to adjust their mistakes, but not really letting go of your peace of mind. And he told me the story yet about one young neurosurgeon, so who had made a fatal mistake, but despite so during in the course of the surgery process operation, so everyone is prone to make mistakes. So whilst he was in training for Dr. Marsh, so it was a fatal mistake, as I won't disclose his name, but as of now, it is one of the leading British neurosurgeons of the world standing, and basically. So the main, perhaps, I just would like really to go back to my first statement ever. So to be a teacher, so should be prestigious and should be of value, and the society should acknowledge and should appreciate not only the ones really who have the gifts of really the surgery skills, and so there should be thankful to the trainers who train so good professionals for the benefits of the society.
Great Britain. If we are talking about postgraduate education, let's say there is a resident, young doctor, an intern, somebody in the clinic. Who is responsible for it? Is it the clinic itself, or there is still a role of the university?
No, it's a national system. There's a national curriculum in each medical specialty, which is specified. You then have to take an examination at the end of it, which is nationally organized, although it's run by doctors. So it is not left up to the individual clinics. They have to fulfill the national guidelines and achievements. But the point is, it's practical teaching. These postgraduate doctors are working all the time in hospital, and they're being trained on the job. Because medicine, particularly surgery, is a practical craft. You learn it by doing it, and you have to have the master and apprentice model. And if it's very dangerous surgery, as we all do, you start, your trainee does a little bit of the easy opening and closing, and then as the months go by, they do a little bit more, and then gradually the teacher steps back, and then he's sitting in the operating theatre watching, and then maybe one day he's outside the operating theatre. It's a very slow, gradual process, but it is strictly organized.
Does it happen that, for example, this intern or resident saying, I don't get enough here in this clinic, I want to change it, or I don't get enough from this team of doctors, they don't teach me what I want, or they refuse me in practicing?
In America, there is slightly more movement. In England, there is not very much. You have to, it is decided at the beginning where you will train, and then you have to accept it. But
so
some
you
of
do
the
not choose, you are sent somewhere.
You have not very well. You have some choice. It depends how you do in your examinations, and some training hospital. There are in neurosurgery. There are 35 neurosurgical departments. They will all be training to some extent, and some are much more popular than others with trainees.
And the exam will be not only theoretical, but
the
as well...
exam has two parts. There is a theoretical multiple choice part, which is frankly, it's a bit like, abstract theoretical stuff. But then there's a second part where you see patients, and you have examiners watching you see patients. You can't examine operating, but you have to talk to patients, make a diagnosis, and then tell the examiners what the diagnosis is and how to manage it. And this is very, very carefully regulated by educational psychologists. And so bullying, harassment, you're not allowed to do that. I was an examiner for 20 years, and you were given very, very strict instructions about how to behave.
Andriy mentioned the situation when one of your students made a fatal mistake. And you mentioned psychologist, educational psychologist.
Yes.
So what happens to the poor thing who really made a horrible mistake? Because I remember what happened to me when I thought that I made a mistake, which apparently was not true, but the patient died, but I for 3 days was sure that it happened because of me, and I was totally stressed out completely.
Well, it is very stressful, is the answer. We all make mistakes. I think you can make a mistake once. You start worrying if you make a mistake twice. And as a trainer, I've trained hundreds of neurosurgeons probably, many from America. You know, you will sometimes have a trainee who should not be a neurosurgeon. And that's very difficult because the problem is not that they can't operate, it's not that they got hands like feet, it's all psychology. And that is largely, when I think about the small number of trainees I had, who with other senior doctors, we had to tell them stop. And it's difficult, they do not like it. Often you're accused of being a racist or something, you know. They were usually people who were just too confident. They were not sufficiently self-critical. It was a psychological problem. Or sometimes they just could not deal, they could not make decisions properly. The operating is the easy bit. There's this big myth that surgery, particularly brain surgery and cardiac surgery, calls for fantastic, you know, golden hands. Complete rubbish. Once you've done enough operating, skill in surgery is simply experience. The big men are good surgeons, not because they're brilliant, but because they've done a lot of operating. Simple as that, as of any skill. The difficulties are all about your relationships of your colleagues, your honesty, your relationship with patients, and your decision making. That's when things go wrong. The operating is easy. That's just a question of sufficient experience. But this nonsense about doctors being magicians of their fingers is because as patients, we are so frightened and so in awe of our doctors. We treat them as though they were gods, and many doctors end up thinking they are gods, you know.
Оскільки ви вже дорослі і навчаєте
Just because you're all grown ups and you're out there instructing someone else, what would you change in your own demeanor towards teaching the others over the last 5 years or during the wartime or so? Or do you only doing your own instruction and teamwork exercise or an individual approach? Or so do you beat them up? Or do you get a educational psychologist for that matter? What have you changed? So how do you train people? I'm happy to share my experience over the last 2 years. So prior to the war, and as many as 40 foreign cardiosurgeons came round to see those minimal, mini invasive surgeries, and based on their experience, and I managed really to improve that method of micro-invasive cardiac surgery, that in conjunction with the Invasive Research Institute. So we are trying to perform, and I'm here to train, and as many as 20 trainees have been exposed to this training. So the ones really who undertake this, and how do I get on? So in my relationships with them, so in the course of few days, you can really end up having an impression, so how that person will be fit to be able to perform such surgery single-handedly, just because it is really about the subtlety of discern minutiae and to be able to train to ask the important, vitally important questions. So in this respect, so you can tell by and whether it is possible to pick or to select the surgeons who are incoming and choosing this profession without them really giving them a training ground, so immersing them into the trade. The answer is no. That is why, so upon the end of the university or undergraduate studies, you have an internship setting, so for all these specializations, whereby the students, the graduates, medical graduates, undergraduates. So something that you don't have and something that can be very beneficial. They're exposed to intensive care and to therapy, to the surgery, and to the other so more general professions, and they are fully empowered. So in the course of those 3 upcoming months, when they will be exposed to surgery, they will be able really to have a go at it. And sometimes we are challenged with the fact that those youth really dream work about those youngsters who would like to make surgeons really come to and not really they are destroyed in the very first weeks because the people are not ready to withstand this reality, past realities, that it's too tough, that you should sacrifice a lot of your life so to make a success story, to be able to withstand the avalanche of the self-criticism. So in your regard, it's really painstaking. My advice to you, so whenever you're talking about what it should be done to be able to choose, so whether to become surgeon, as at least you must spend so several weeks of your life, so in a real circumstances of surgery, and after that, if you get to like it, and if you would like really to hone some techniques and take away home message, and you're not stopped in your tracks whenever a surgeon who is operating surgeon so will criticize you and so will tap you on your hands. So because you must be very down to the letter, down to the point, because if the assistant is not is malfunctioning, so you are short of time really to say, excuse me, but can you please remove your instruments from the wound because you will derail my really membrane in the atrium, and the female patient will end up having a negative result. So you just have really to tap that instrument, and he will just get on his toes. So this is not a bullying really. So what Henry was speaking about here, he was meaning about something else. Can we say? So what is the and how about the U.S. Marines and Navy Marines? Be comfortable, be uncomfortable, and I think that for any medical, so who's entering into their trade, so the very first years are not comfortable enough for them, but it is our mission as that of the trainers to make sure that they are as much efficient and as much comfortable as possible. So being able to perceive all those challenges. And Andriy, how about you? Well, you must know my approach towards training, so it's really to be able to come around and share knowledge. So hasn't been modified, hasn't changed in the course of the war or COVID-19 impact. So I must really acknowledge that a certain selection of our trainees must be there in place. So and actually to take a one-off, really to make a good surgeon out of them, so you won't be able to succeed. And what is the eligibility criteria? So to the best of my mind, these haven't changed. So this person should be there really to share a certain number of your values or virtues, for that matter, if you like, because Sashko has now said being comfortable and uncomfortable, and if let alone your trainee or your apprentice, as you keep calling them, so shares those values which you then the apprentice shall feel comfortable in uncomfortable circumstances because they will be given an assignment and to perceive the understandings that they will have really to repurpose themselves to work hard for at least several years to come as a U.S. Marine Corps in the surgical field. Then they will feel quite comfortable enough that it is really about their golden years of training, and later on so it will come in handy to them to make a good specialist and to feel well protected so they won't have really to have any inadequate really repercussions to the colleagues critics or criticisms, and let alone so a younger person who is looking to make a physician, so has this stock of virtues, as Dr. Marsh is really saying in their mindset, then they will make their hands. And neurosurgery or cardiac surgery is not about the hands, it's not about one's golden hands, it is about a good mindset. It is about their what they think as a surgeon. So that is why the virtues to share really come first. And my add-on here is actually a wonderful thing that I really by instinct try to introduce, and Dr. Marsh has voiced it, problem-based education. So you don't have to really look into those big volumes, thick volumes, really to make those cascades and flowcharts that we used to draw coagulopathy and Krebs cycle. So you should be really upfront. So you have such and such disease, medical condition by the bedside. So the treatment process such and such, and you do case study. It is a problem-based approach. So to the best of my knowledge, so not to the best of my knowledge, but I'm quite convinced. So we must introduce it, and we have the old one, inherited one style of peering into thick volumes, and and then the person really by the bedside and don't know what to do.
The system is extremely corrupt, and we know that all the efforts of a lot of efforts of different various donor programs, which are, for example, funded by US or by Great Britain, are first of all anti-corruption. And I think that it relates directly to the situation with the education, especially postgraduate education in medicine, because in my times, for example, to get the space you want, you need to pay. And then even if somebody gets the space they wanted, then they have to pay to get to the operation table or to some practical issues. Now people say sometimes it's a little bit easier, but not everywhere. But still, coming back to what you said in the beginning, that somebody should set an example. What do you think? Should it be some university which will set an example of revolutionary university which doesn't do it like this? Or it's more the hospital, from your experience with Ukraine, who will finally start and set the example? Because it has to start with something. Somebody has to come up and say, from this day, I will start corruption. Something new, and I will,
only Ukrainians can solve Ukrainian problems. If it's a university, you have to persuade the teachers, you will have less money. You will not get the bribes from the students. And if it's a hospital, you have to persuade them you will have less money because you will not get the money under the table from the patients. So, there's no easy answer to that. It does trouble me greatly because although there are very few voices in England against support for Ukraine, one very famous political technologist called Cummings, who was Boris Johnson's advisor, did an interview last week in the English media saying Ukraine is a mafia state, totally corrupt, it's ridiculous that we are supporting Ukraine. And it's awful for Ukraine's reputation in the world that this corruption is known about. My answer is, well, if the Russians win, Ukraine will become even more corrupt. So, so it's not good. But I think, yes, in an ideally, you want to have what's called best practice. You want to show, whether it's a hospital or a university, I don't know, to show you can have a system which works without corruption at every level. But there's no easy answer. That comes down to the economic situation. You cannot have first world medicine in a country with a second world national income, particularly in a time of war.
Let's imagine that you are now a CEO of a big hospital in Kiev, for example.
Yeah.
What would you change, or what would you set as a culture of education in the big hospital? Let's say you come and you say, let's guys do what from the perspective of the postgraduate education?
There are many aspects to that. I guess I would try to introduce proper outcome analysis, morbidity and mortality, proper morbidity and mortality meetings. I've been to more M&M meetings all over the world, and they often don't work very well The ones which do work, and the M&M meeting is when you look at your last month's results, you look at the bad results and say, what could we have done differently? Bad results, either death or injury. And that really requires good leadership from above. It needs a good senior doctor. So I guess if I was in a hospital, I would try to find senior doctors who were keen and interested and understood the importance of learning from bad results and analyzing bad results. I think that's where I would start.
Mm-hmm. And coming to details of such meetings, from your experience, since you saw lots of these meetings in the world, yes. What works in the meeting itself?
What works is, first of all, if there are reasonably good working relationships between the senior doctors. If the senior doctors all hate each other, as happens with some surgeons, the meetings just become people throwing abuse at each other. And it's all about their egos rather than about what is good for patient care. At the same time, you want to avoid the English tendency to say, oh, there, old chap, don't worry, bad things happen, and then you brush it under the carpet, we say in English. So you need to find a balance between criticism and cooperation. And that is all about good leadership. Having a senior doctor who runs the meeting is very important. All the senior surgeons are at the meeting and that they talk about their bad results. The tradition tends to be, in England and America, that the young doctors present the bad results, and often the young doctors hesitate to do that because, they do not want to say my boss made a mistake, both for obvious reasons. But you have to start with a senior doctor who, in each surgical department, we're talking about surgery here, who likes the idea of trying to run a good morbidity and mortality meeting. That also means good data collection. You need to keep a good record of what happens to patients, which is very difficult, particularly in a big country like Ukraine, particularly in a time of war. So nothing easy. There are no quick fixes. You have to accept it's a very slow, long-term business. But you must try. Just because it's difficult does not mean you should give up, just as with the war.
And where would you start off? So in the hospital setting, let's take the hospital. So I will share my reflection first. So the statements by Henry. So he's turning up with an example. So from the peer-to-peer culture. So if you have peer-to-peer setting among the clinicians, so with the head physician and immediate superior in their department, so then these meetings kind of so if you have a good management in place, so either will yield outcomes and results, you will get down to the gist of the matter, or they will be at loggerheads, but it will never be a disciplined kind of instrumentation to make some introduction. So it's really to grasp at this opportunity and to capitalize on the experience that I'm in full respect of it, and I've been so in it myself. So first of all, you should level out so the rights and the entitlements of the physicians, because these rights are not equal. So if they are organizationally, economically, professionally, they are dependent on the chief of the clinic, on the boss of the clinic, and they would like really to delegate their responsibility to the head of the clinic, because it takes really the clinic, the hospital setting to be accountable for all the outcomes. And whenever the hospital is accountable virtually for everything, they are vested with the responsibility to run the physicians, so up to their discretion, fully to their discretion as they find it convenient. So the system itself won't let us implement those best practices we have available. And what do we need to do instead? We should to make really the equal rights for the physicians, and we should license the physicians. And it is not an exact version. And it is, the license is all about the entitlements and accountability, responsibility for the physician to assume. And So the entitlements, the rights for the economic activity, and then you will be given the choice to make, and then you will have the understanding for the physician. So if they have to, so the problem, so in one health facility, because of the leadership, they will exercise a free hand at choosing their pathway elsewhere. So this is a few more words about the corruption to say here, because in the medical education, so there is corruption here as well. But I just would like really to make an emphasis. So the corruption here right now is not about the fact confined in the exams. That all of the students are mandated really to have some kind of financial relations to enter to with the head of the department or with the physician. No, no. If the student is in training here in the setting, and if the student pursuing their own specialization, so now the exposure of their education, they will never enter into corruption. So corruption is all about the fact that whenever is a bad student, so for academic achievement, so they are standing pretty much the same chance of getting their diploma, degree, and seeking employment, just like with the other students who makes good academic achievements. So this is really where the corruption steps in, and as you can see inside, so the system is made happy with it too. So it is about this arrangement. And once again, and I will remain optimistic here. Huh. So not in this statement as attributed to Oscar Wilde to say that so he wanted to be optimistic just because when really getting rid of all the substantiations he didn't come across any useful one to be pessimistic. So we have in Ukraine some universities, so I won't quote which ones, so who eradicated virtually the corruption and the youngsters become students without the need so to grease someone's bum and actually they assume really the highest links of in the reputation shortlists, and I'm a driver and I'm so I appreciate our petrol police, the ones that I'm coming to grips with, and I'm reminiscent to what we had to have before in Ukraine. So we thought the system was invincible, but we do have some very illustrious examples to show that things can happen, so we can change it. And I'm looking forward to this change to come around in medicine. So from my own behalf, I'm trying to to show an example by the way that I'm always uh, proactive. um, So in displaying and showing my own mistakes and my failures. Some medical administrators really find me kind of eccentric weirdo whenever I'm telling them that I've made a fatal mistake, and because of the outcomes of my activities, something irreversible. So they're trying really to shove themselves apart from myself because it is out of their way. How the so you should really put it under the carpet, and you should really say so that you are success best ever. And I'm displaying my errors to my colleagues and younger colleagues just to show how it happened. So it's really for them to realize how it happened and to make sure they're everything utmost to avoid it, or surgical lifetime pretty long, and sooner or later it might happen to you, might occur to you, and you will be at a loss how to do it, and you will be able to survive it someday because you will know that one of your teachers has come across this before, and things happen. And I'm trying, and I'm actually keeping a great deal of optimism. And I would like really to agree with Oleksandr to say that indeed we need to remove blame culture, that sorting out the case studies and their errors and mistakes so it's done not really to put punishment on someone, but really to better understand the situation and to be able to display your own errors and to be a teacher to someone else. You should be confident in yourself, and to be confident in yourself, you should become a good U.S. Marine Corps and to be able to do that, so and work comfortably in uncomfortable circumstances, virtues and values.
The word outcome. Speaking about, for example, hospital. In my understanding, people are interested in outcomes if the value of life is quite high, or if there is a competition. For example, I want to have a hospital where patients are really coming more and NHS is paying me more because the results are good.
Yes.
What do you think about that? And are, for example, the results and outcomes of the hospitals made public in England? Can you, for example,
Yes,
being a patient...
They are. Whether they are completely reliable is uncertain. Some specialties have made more progress than others. Cardiac surgeons have been very forward about publishing results, but that's because cardiac surgery has two binary outcomes. The patient is alive or dead, so it's easy to count. In brain surgery, it's much more complicated, for instance, because you have many degrees of disability, and disability is very hard to measure. Many patients are going to die anyway, so it is very complicated, but you have to try. And with the NHS in England, the government judges hospitals and publishes the figures. They look for certain markers. So, for instance, bed sores. If you count bed sores, that is a very good marker.
Bed sores?
Bed sores, pressure sores.
Okay.
Pressure sores.
Oh, you do?
Oh, yes.
And it's public?
And it's public.
Oh.
And that is a very good measure of the quality of nursing. And if you have a low pressure sore count, almost certainly that means the rest of the nursing is good. But there is a problem if you have targets, and the government has targets for bed sores, because then, of course, people start gaming the system. They'll, maybe hide bed pressure sores or describe them as something else. So it is having a target-based system, as we have in Britain, it's complicated.
But transparency with the results, you think, is a good thing?
Yes, on the whole, yes.
So you would advise for us to
Yes,
have some results, transparency?
If you're not open about, if you don't acknowledge mistakes, you hide them, you don't learn from them. Things will not get better.
З одного боку, от ви дуже гарно казали, як наш колега з Одеси запропонував якісь...
And our Odessan colleague has put forth a certain format of errors-related discussion, a good idea. So over the last 20 minutes, I've been pondering about it. So if you want really to delve deeper into Ukrainian Facebook, and where the physicians really put up only the best outcomes, and we as the good physicians really should be courageous enough and in a kind of this noble way to be able to share our mistakes in the social media network. Can you imagine how the clinical leadership would be happy about it? So employing that particular physician who made it happen, perhaps it is unrealistic, but say so. And by and large, so for the specialists, it must be in place. But the situation in here, by my hypothetical situation with Facebook, and the response is recurrent and repeating itself inside the health facilities, because any professional is afraid of acknowledging their own mistakes, because you have admin people by their side. So we have so tremendous success all over the place.
Coming again back, so the transparency, and then the thing that you can discuss the mistakes, and it's with the good leadership, let's say. If to discuss the program itself, so on one hand you mentioned that it should be as practical as possible, so as much around the bedside.
Yes.
Anything else you see as a huge difference between us and, for example, British system now?
No, on the whole not. I think the hierarchy and patient-based, problem-based teaching, as far as I can see, are the two of the biggest differences. I've met many very good doctors here, but I've also seen some unimaginably bad mistakes, which are almost inconceivable in England. Having said that, mistakes are happening all the time in England. I'm not saying it's wonderful, it's not. But some of the mistakes I've seen here suggest to me this is not bad doctors or stupid doctors. They're doctors who have not been properly trained.
Can you give an example? Without saying who was
I
there
saw
and
one
when?
case of a patient who had a hemorrhage after a brain operation, which is a standard complication and risk. All after any operation, there can be bleeding. And in brain surgery, because the skull is a closed box, even a small hemorrhage, 100, 150 milliliters, can cause death or terrible damage. And I saw a patient where this happened. There was a hemorrhage after surgery and nothing was done. Even though we said, you must do something, you must immediately reoperate on the patient. I could not believe that. And I still cannot believe it, but I saw it with my own eyes. And these are not bad doctors, they just clearly were very inexperienced, had not been properly trained in one of the most fundamental, simple principles of operative neurosurgery.
And I just would like really to pick up a very important. So Henry is really saying that so it should be bedside-based training, and it's a proven fact and truth not only for the postgraduate and for the undergraduate training. Because some universities, and you might want to ask more from Henry already starting. So to get to know their student by means of the clinical medicine. So practically, so from the first year of studies, and it is likewise very important. And whenever I'm busy traveling in my duty travel or business trips, and so it is a hospital clinics, what I can see happening there is that the instructors, the teachers, throughout practical sessions, don't have more than 1 or 2 students to look after, and the student is just following the teacher's footsteps. So, and it doesn't really derail the physician from their main activities to engage to. And they should be physicians, doctors. They don't have to have the teachers who are not professionals in that clinical domain. And I think it will be interesting. So literally yesterday we had Henry talking to us about two systems of undergraduate training, postgraduate training. So so concentrating on its interaction in the UK. So interesting to know about it.
As I understood that you had a discussion on
The tradition in England is 5 years for undergraduate medical education is 5 years. Until recently, usually it was 2 years of theoretical lectures delivered by doctors, but they were not practicing clinicians. Rather like the old Soviet model, they were purely teaching doctors. Which some of them were research scientists, some of them maybe were unsuccessful doctors. And then you had 3 years where you were in a hospital. You each, every 2 or 3 months, you would be attached to dermatology or to neurosurgery or general medicine, and you'd spend the day on the ward with the doctors, and the junior doctors would teach you, the senior doctors would teach you, talking all the time as you saw patients. In some medical schools now, they start exposure to patients in year 1, right from the start. At the age of 18 or 19, you'll be taken to a patient and you'll be told, talk to this patient, find out what's wrong with them. And more medical schools are having that model and with problem-based learning. Many medical schools now have stopped cadaveric dissection. The role of anatomy in medicine is very historical. It goes back to Vesalius and then pathological anatomy, Rokitansky, people like that in Germany and Austria at the beginning of the 19th century. And you still do anatomy, but of course so much now is scanning, and you see such good, just like you don't need to do post-mortems now. You can do a post-mortem MRI scan. The pathologists are not happy. So the technology is changing all the time. But the teaching is it increasingly patient-based. Yeah, and I think that's good on the whole.
Speaking about that, books. Books are the huge problem, I would say, because as you know, we have this Ukrainian science,
Yes.
Ukrainian medicine,
Yes.
tons of different books which you are supposed to buy.
Yes.
So what do you think overall about the books, and what is the approach in Great
Well,
Britain
because I
for the
don't
books?
read Ukrainian, alas, I cannot easily judge the quality of the Ukrainian textbooks. Superficially, my impression is they're not very good, and the English language ones on the whole are much better. And of course, there is so much on the internet, a lot of videos as well, and you have to know which websites to trust and which not. But that is a big contrast to when I was a medical student. You had to go to the library and get down a big book and journals. So the access to information is much easier now. But again, coming back to what we were talking about earlier, I think in an ideal world, medical schools in Ukraine should be taught in English.
Mm-hmm. And more with protocols or more with the books? Where are now the books and where are now the articles and the protocols or evidence? What is the trend in Great Britain for the moment to use? Or do you still have the Bible of surgery, Bible of pediatric, Bible of infectious diseases?
You have both.
You have still, yeah.
You have both. But the tradition of big text, it is disappearing. And I mean, and many of the big textbooks now come with a website or with a CD. And also these textbooks are so expensive. I mean, the standard American neurosurgical textbook is 4 volumes, that big, and costs, $1,500. But then there are pirated versions on the internet.
Я, власне, хотів доповнити те, що сказав доктор Марш.
And my quick add-on to Dr. Marsh's statements, and I've got an answer to your question to say whether it should be handbooks or the article. So whenever I was busy talking about the virtues of values, so it kind of sounded pretty abstract. And one of the virtues is showing interest, curiosity, agility. So if you are interested in your profession to pursue it, so you will be an avid book reader, so at least the Bible really to have a historic insight into the profession. So and you will be browsing on the web. So when I was a younger doctor and I was traveling abroad, so I was in the university library and it is no longer in demand. So by means of Google, you can get access to any type of a monograph or article, at least pay some money for it, and the state-of-the-art know-how and technology on the web. So make our life easier, really. And the problem is, so have use of the person who is training in medicine should be keen on it to find out, should really take and they should find it interesting. And I like to reiterate now that command of the English channel, of the English language, is more important than Latin language before. Because you could really wait for 6 months of 12 years to find the Latin language medical treatise brought to you from Europe. But now access to information really is groundbreaking change undergone. And if you don't know the English language, if you cannot really have this English fluently, you won't make a state-of-the-art professional. As Anastasia's definition comments from the TV viewers, we might have very good debriefings of clinical cases when the physician is legally protected and nurturing this culture that the speakers have referred to. It's a big check of work ahead of us.
Protected from malpractice in Great Britain.
You're insured if you work in the government sector, which we all do. You are insured by the government. If you do private work as well, and many doctors work for the government in the daytime and then do private work in the evening, you have to have your own private insurance. So litigation, although it's more and more of a problem, is not entirely a bad thing. I mean, I hate it. I always got terrified when a letter came from a lawyer. And I was only sued think 2 or 3 times in 40 years, but it's still horrible. But it seems to me one problem in Ukraine is that patients here are in a very, very weak position. They have no redress if they think a doctor has treated them badly or there is a bad result. I do not really know if they can do very much. Whereas in Europe and England and America, you know you could get sued. Although you will not lose money, shame, embarrassment is a powerful stick to make you treat patients a bit better.
So it's not about money or about
No, it's not
going
money.
to, not about losing your job or not about going to prison. It's only about reputation.
It's professional shame and reputation.
Окей. Ви хотіли б якось прокоментувати це?
Would you like to say a comment here as well? So we are just getting into a very interesting stuff here, talking about the clinical mistakes and treatment mistakes. And if you want really to put it up to a government level to find out how the government might, so which expenditures it might incur. So these institutions, they might get into a very big budget. So that means those tips and advice. So whenever the United States are looking to bring down, so to reduce financial workload on the government to bear, so because of those litigations and courts, and their advice is all about the fact, so it's really need to have as much communication ongoing as possible to make sure that all those clinical mistakes or slips and errors in the treatment process that there is no way to avoid, so it needs to be addressed in the setting of the physicians whilst communicating with the patients, so trying to provide clarification, so it's really to have as much less litigation to be put on the funding shoulder of the governments to bear. Did we got another comment from the audience? Maria Kiseleva is writing, so thanks for a philosophical and practical considerations required to become a high quality physician. Our society is not ready to perceive a physician, so the perception of the physicians is the toolkit to have the best treatment outcome for the patient. And the toolkit, the instrument, is not prone to making mistakes. So, and a question to ask for Henry.
This huge debate, and we still have it. Whether, for example, doctor is doing this good practice or providing the service. Some doctors are saying, no, we are not servants to provide the service, we are gods. Some are saying, yes, we provide the service. And the whole debate about all this big respect and how this respect should be expressed by society and how are we treated as a doctors. I mean, if we are not speaking about money, because financially, of course, the situation in Ukraine is not appropriate if we're speaking about the salaries. But if we take money aside and speak about some other, I don't know, respect, reputation.
I believe passionately that it is a great honor to be of service to other people. I regarded my work as a doctor as a great privilege because I could serve other people. And that is what I've always taught to my trainees. We are here to serve our patients, and that is a great privilege. There is no other profession, there is no other work which human beings do, which we have as doctors. I despise and hate doctors who think they deserve automatic respect just because they're doctors. If you are to be respected, it is because you are of service to your patients. And that is such a privilege. You might make millions of dollars sitting in front of a computer screen all day in a bank, but at the end of the day, it's rubbish. It counts for nothing. I have cancer. I don't know how much longer I will live, but I can look back on my life and feel I was of service and helped people. If I had made millions of dollars, what's that worth? Nothing. Nothing at all.
Я погоджуюсь абсолютно з доктором Маршем.
I would like really to agree with the opinion of Dr. Marsh. So I don't see any clash between the patients community and medical community. My personal experience really telling me that if you are indeed. So you are very devoted, dedicated to take to assume these commitments. So it might be pretty to be of service. So it's pretty highbrow as a statement. So and the patients will do you credit. So they will always be thankful to you. So and for many times I've been witnessing. So to being of service to patients. So making these patients really upgrading the status of those patients. So any moral so tone. So whilst you're trying to have your due diligence with the patients, you will be able to see their so you're devoted to them. So you will be able to unleash their good virtues of their own patient's personality is my personal discovery, and hopefully my colleagues will be able to share it. And I just would like to get back to the question, because the question was whether a physician is instrumental, not instrumental toolkit, and based on the feedback. So my message to you, so whenever we are talking about the healthcare service here in Ukraine, so then we are dwelling on these discussions in the internet. Those are the discussions between what type of relationship between NHSU, so it is the Ukrainian NHS, and the health facility. So those discussions are not really raised. And what is the healthcare system? Those people who are in treatment, so those the people who deliver treatment, and those people who put the contents, or really not the to put the funds in the budget to be able to be recourse to the funding, so the treatment. It's all about the people, and it's especially this issue to look after by, so beside the spotlight of our attention of our legislators, because they draw their attention to the financial, what is called restructuring, so of the funding in the healthcare sector. And so the complete point blankly about the people, and it takes the people indeed who are out there in this Western understanding of the medicine, and we must go back to it, let alone so from the viewpoint of the fact that we need to deliver. So this type of service, because our physician is not entitled to deliver healthcare service, so you must understand well, and that is why it's the accountability that the physician is about to assume, because it takes the health facility only in Ukraine to deliver healthcare service.
Speaking about money, we can theorize a lot, but however, the medical society in Ukraine is very much divided between surgeons who make money and the rest who do not.
Yes.
I mean, if to be very honest, of course, not all surgeons make money, and we can as well discuss whether it's enough or not. But still, what do you think will change or might change the society in a way that it really becomes a well-paid profession, as it actually is in the majority of the developed countries? Because I cannot. I mean,
I think
it's quite well
it's rather
paid.
like the rule of law depends on paying judges so much money that they don't need to be bribed. So it's partly that. You have to pay doctors well, because healthcare, particularly surgery, is very valuable, very precious. There are no countries in the world where doctors, particularly surgeons, do not make a lot of money. So it's partly cultural, but it really ultimately depends on the state paying doctors well.
So it's a big state decision when we say this is how much it costs, and
Yes,
this is
I
what we are ready to pay for
think
our
so, yes.
safety and
And
health.
it's difficult in a poor country at war.
По-перше, всі, хто нас дивляться, ви можете
First of all of the viewers, so please feel free to come around to Henry Marsh's lecture at 5 p.m. in the Kyiv Mohila Academy. And secondly, I just would like you all, so in this sequence, so this kind of takeaway home final message. So what are you looking? Final takeaway home message. So if you're talking about the medical education, for that matter, so the medical education, yes, first of all, you need so to look at it that it is not kind of standalone, because it takes the instructors, the teachers in the medical education, those physicians slash doctors, and the clinicians is all about medicine. and the Achilles talon of our medicine and that of our physicians, and is the really is the dependence of that so shadow medicine, so from out-of-pocket payments, informal payments, so they're just made to do so, and it is a sheer fact that should be raised and it should be out in discussion, because without so the resolution of this problem, so it doesn't matter. So if you do so improvement of healthcare, of medical education, if you're talking about self-governance, so that is not the problem solver of this Achilles talon so of the medicine. So we won't make any further strides ahead, and the capacity about medical education is in place here, and we've got something to display to the wide world, and the fact that the Ukrainian physicians who are migrating out of Ukraine, they seek very successful employment elsewhere, and they make very successful stories in the medical education. And so that means that we should redesign our system, and all of the agenda raised today so doesn't touch base on some interpersonal relationships in the people inside. It's all about medical arrangements, the arrangements, the governance and the medicines. It should be number one spotlight for the relevant parliamentary committee in the Ukrainian parliament. So, and our very own ministry, it must be their mandate every day, because otherwise you won't be able to get rid of those problems on our shadow medicine. And so a share of the good command of English, so in the medical education and in the routine daily activities and in training should be increased significantly. They should be able to have a good command of English language, and they should be able to improve their knowledge of the English language, and you should really be able to manifest the examples of brutal honesty, and after action review must be instigated, so they must be exposed to it by all means, and no blame culture must be introduced here likewise. And our expectation is actually, so when we have a very marvelous team here, so when we are above board talking about it, so we are in the inception of it, and we keep optimistic. Thanks very much for inviting us here. So to touch base on this tremendous topic, and Alexander has been one of the, and I agree with it, so I'm all for it. So the one who was the initiators of this talk. So brutal honesty, as you've said, and it made me, Hamlet used to say, to be kind-hearted, you should be cruel. And I think that it is an ideal supplement in the meanings that I really introduced.
To the viewers. As
Слава
of
Україні.
Героям слава. Дякую вам всім дуже, всім дякуємо, хто нас дивився.
Thank you very much indeed, our viewers also in live transmission, and who will catch up later on. Thank you.